Hello, everyone, and welcome to the Quorum podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Averill Kelly. This week we have another Medicine in the Mediterranean conference presentation. Dr. Trevor Abela is a PhD nurse who is the head of the nursing department at the University of Malta. The ambulances in Malta are operated by degree-level nurses. Most of them have a master's degree in emergency nursing or are actively pursuing their master's degree. We have some of them on our own Masters of Austere Critical Care degree program. Here is Dr. Abela discussing the pre-hospital nurse.
Most of my clinical practice was in emergency care, the vast majority of which was in pre-hospital care and the ambulance service. Since for most of you it's the first time in Malta, we thought that being the only Maltese speaker, we'll welcome you to Malta by showing you a couple of pictures. Obviously enough related to our area of practice. So welcome to Malta. Just to put everything in perspective, especially my conversation with you, we need to understand a couple of things about Malta. Malta is a very small piece of rock, surrounded by a lot of water. When I say very small, it's very small. It is 1/5 the size of London. That is small. Surrounded by a lot of buffer, which is water. And that maybe it makes Malta a remote place in itself, but a controlled remote place. So just to give you a brief idea of what Malta went through over the years, just also to put my discussion with you in perspective. Back in 1915, we got 30 ambulances donated by the UK, like most other things. And we're talking something like that. So throughout 1915, we got 30 ambulances. If I'm not mistaken, that's a Ford. Before that, it was something like this. So for those of you who know about Malta, that is the port in Marsa. One of those is, well, a replica of it, is available in a place called Khalfarouj. There's this huge hall, which is more or less a museum. It's a museum of horse carriages. So you can see one of the old carriages or an arranged version of it over there. If you look at the picture closely, very conveniently placed next to a horse-drawn hearse. So that was where it started. The first documented evidence of nurses being on an ambulance in Malta is there. So this is the Second World War. There was this nurse, someone called T. Fenech, presumably something like Tony Fenech, or Thomas Fenech, a very common Maltese name. And apparently he was a very capable nurse who was on one of the ambulances helping extricating someone from underneath rubble. That is the first historical or documented evidence we have of nurses being on ambulances in Malta. Now, as Abrick mentioned, in Malta we don't have paramedics. In Malta we have a nurse-led ambulance service. It is sometimes mistakenly labeled as a Franco-German service. Yes, we still have that debate going on in Malta. Again, there's a lot of water buffering us from mainland Europe. And sometimes we still have that debate going on, Anglo-American versus Franco-German. We don't have a Franco-German system. We don't have an Anglo-American system. We are Maltese. We take the best from both. Fast forward a couple of years, 1965, ambulances resembled more like vans now. And nowadays, we're looking at that. So I remember working in the first ambulance, in the one below, and the Ducato next to it. I don't remember working in the Dodge, but I remember it going around the island. And now we have these 4 vehicles over here. All this is controlled from this room. Now the system is a bit maybe different from some other countries in that this room, the ambulance control room, is within the hospital. And when I say within the hospital, so if this is the main area of the emergency department, that door is the door to the dispatch center. So it's literally across the door. Over there are nurses, usually experienced nurses who take triage calls, dispatch the ambulances, etc. They can control where the ambulances are, where the vehicles are, etc. Over the past, I think, 3 years, 4 years, we have introduced what we call the rapid response vehicles. So we have 2 vehicles roaming the north part of the island, if you can call north and south in Malta. So the top part of the island, there's another one roaming the lower part of the island, and the ambulance is dispatched in the center. Response time varies, but for what they call code reds and code oranges, it's a very short response time. Keep in mind, from Mater Dei, which is the center of the island where there's the main hospital, to the edges of the island, without traffic, should not take you more than 12 minutes. So to cross the island from Marsa Scala to Cirkewa, on a moderately good day, it's about 50 minutes to 1 hour. So, I mean, this is a small place. And that's how it works. Earlier this morning, one of the speakers mentioned the fixed mindset. And having an island mentality and being very much influenced by our British colleagues and having a fixed mindset, Malta changes very slowly. So we can still see some remnants, if you want, of things that happened 20, 25 years ago. So sometimes, that's why I said earlier, we still sometimes debate whether we're a Franco-German system or Anglo-American system. Those of us who've been in this for quite some time, we know that that's an obsolete conversation now. Just like paramedic versus nurse. Sometimes we still have that conversation nowadays. Again, things take longer to change in Malta, but we're seeing the change. I'm going to talk about nursing. And despite I've been a nurse since, I don't know, 2001, I really started thinking about nursing when I passed through a personal experience. And has nothing to do with prehospital care. So for about 20 years, we used to take care of my grandmother. She was living with dementia. She used to live in her own house next to my mother's house with various doors going to and from one house and the other. So after something like 15, 20 years taking care of her, we were getting concerned that, you know, sometimes you find an oven with the food still cooking. Sometimes you get concerned that she'll be upstairs, falling the stairs, things like that. So unfortunately, we had to get her admitted to a residential home. Something like 6 months later, we got a call that she was severely injured. And by severely injured, basically, to cut a long story short, she managed to wheel herself out of a dementia ward through a fire door, falling a whole flight of stairs, strapped in a wheelchair. Not for the conversation today, more for the psychotherapist, I wasn't angry at that, because we know shit happens. What I was angry about was the way nurses reacted to it. So I was more disappointed in my profession than in the fact that my grandmother died. Obviously enough, she died. And that got me thinking, why did they lift her off the floor, took her up one flight of stairs after following that massive trauma to put her back in a bed? Why was nothing documented? Why was, when my colleagues from the emergency department, when they were asking questions, why did the nurse accompanying my grandmother, she had no idea of what happened to her? But then, something like 2 or 3 weeks later, it dawned to me, what if 10 years ago I was that nurse? So I started thinking about nursing. Because as I think yesterday in the afternoon, there was a conversation going from here to there. A, B, C, D, etc. Sometimes we train a lot. And we condition ourselves to react to what we usually call real emergencies, at the expense of something else. And that something else is usually the patient himself. So we are able to manage a patient's airway, but we forget the person in that patient. We are able to, I mean, don't get me wrong, I like the occasional catastrophic bleed or the occasional KICO situation, but we forget we're doing that on a person. And that may be where my nursing comes out. That we're doing these cool techniques on persons, on people, within a context. And that's what I would like to talk about in the next. 2012, I was a first-year PhD student in Coventry University. Back then with the late Professor Malcolm Woolard. And I remember this conversation with him, and I said, I want to look at the way, what nurses need to know to be able to work in a pre-hospital system. And basically my idea was that colleagues over there who work in pre-hospital care should have their own specialty, being detached from hospital, like paramedics do. And I remembered Malcolm telling me, are you sure you want to look at that? Why don't you start looking at what the patient needs first and foremost? And this is the end of it. So basically the rectangle on the outside is the pre-hospital setting. Nothing new. We work in an unstructured and unpredictable environment which is dynamic and unpredictable, with limited human and limited material resources and limited clinical and non-clinical information. Paramedic colleagues, medical colleagues, I think is the same. The ovals represent the professional. The outer oval is the attributes that we have. So most of us over here, if not all, we are good leaders, we are responsible, accountable, adaptable, flexible, we understand, we have empathy, whatever that means. We are hopefully emotionally intelligent, and we are able to collaborate and cooperate. Within that, we have good knowledge and good competence. And that's the professional. We always miss one other person, the patient in the middle. That is where care occurs. So for the next 20-25 minutes, I'm going to only talk about the circle in the middle, which is where care occurs, the context of care, and what we mean about care. So 2 things I want to discuss with you today. What is nursing? That's not a mistake. Capital N nursing is when we talk about RN, the registration part of it. Small n nursing is something different. The small n nursing is what I want to talk about. The big N nursing, that's what Abrick and myself discuss on the side. But the small n nursing is what the patient is interested in, what the patient needs. And what are the constructs that shape small n nursing care in the pre-hospital setting? 2 questions. Spend 15 seconds, think about. What would you consider to be a successful pre-hospital encounter?
Finding the right scene.
Finding the right scene, having the right address.
Yes.
Yep. Yes, bitten there twice. One of them was a cardiac arrest. What else? What is a successful pre-hospital encounter? Being good at the basics, yes, of course, from the fundamentals. You address the actual reason they called, and that's a very important construct. You address the actual reason. Sometimes it's not clear. Sometimes they call for chest pain, where the call is something else. So I'm happy that no one mentioned having a resus where the patient survives. I mean, we've had positive encounters where the patient died anyway. We don't measure, even in emergency practice, as you well know, we don't measure success by the lack of mortality. Success is something else. So that's the first parameter. When I started, it was about the ambulances. It wasn't about the persons inside them, it was about the ambulance itself. We had a good service because we had a Dodge ambulance that was, the wheelbase was too long to travel in Malta. Is it about transporting the patient? Is this just about transport? There was a debate, I hope it's not on anymore. Was it scoop and run or stay and play? And for a couple of years, we had a consultant who used to go by scoop and play on the way. Scoop and play on the way. He was an anesthetist, by the way. What is a nurse? Is it someone who wasn't successful at getting into a medical course? Is it someone who, is almost just like a doctor? Hopefully we're past that. Who does nursing? Small n nursing. My grandmother, the same one who died, used to measure her own HGT and used to prepare the tablets for my now late grandfather and measure their own blood pressure. Does that make her a nurse? These are serious questions. I'm not taking the piss. Simply because 2 weeks ago, I had this conversation with a professor of radiography. So he came to me and said, and do you have someone who can teach our radiographers some nursing skills? And I said, well, yes, of course. Like what? They wanted cannulation and the insertion of a rectal tube. Because only nurses do that, apparently. They are nursing skills. So see what we do sometimes? we diminish our professions to the tasks we do. I'd like to think that as a nurse I do more than giving bedpans and urinals. And this is a real question, but I asked permission to pose this question before I did it. What is the worst thing that ever happened to nursing? How many nurses are there in the room apart from us two? What is the worst thing that ever happened to nursing, in inverted commas, just for the sake of conversation? Not capital N nursing, small n nursing. We have this conversation quite a lot in Malta. What do you think is the worst thing? Well, not the worst thing, but...
High ratios.
Higher ratios, what do you mean?
So 1 nurse for 7 patients.
Okay, all right. No, there's something else that we believe here in Malta, especially, that it's not a good idea if it happened to us over here.
Or regulated to a hospital?
Well, that's not bad in itself, but that's more the capital N part of it.
Yeah.
There's something else that affects actual nursing care, the actual provision of nursing, and how we see nursing. No time, what do you mean? But there is time for care always. Well, it's nurse practitioners. So we have a conversation over here. I think we were talking about this over lunch now. Why would I want to be... The idea that for me to advance as a nurse is doing some of the things that my doctor colleagues do, to me, does not fit. Simply because where there's a body of knowledge that has to do with advanced nursing in itself. So what we did with nurse practitioners, and I understand there was a need for it, and I understand, and mind you, I'm married to a practice nurse, which is the equivalent of a nurse practitioner here in Malta. So this conversation at home is dangerous. But the problem we see with nurse practitioners is this. When you medicalize, with all due respect, I'm using the word medicalize loosely over here, when you medicalize care, it means that a good nurse is the one who's able to diagnose and maybe prescribe some drugs, or maybe to follow. And what we're doing is we're diminishing the value of actual advanced nursing. We have a student right now, an undergraduate student, who was a third-year nursing student in Canada. For a reason, he had to travel to Malta and started the course afresh over here. Now, first semester has passed, so that for us is 4 months, and he can't fit. Because our nursing course has very little, especially in the initial phases, very little biomedicine, very little A&P, very little pathology, very little pharmacology, because we want to establish a very good nursing foundation, whatever nursing means. We'll get to that in a second. The best thing that has happened to nursing here in Malta, at least, is when nurses started going out in the community. When nurses are also working within a social context. Because now we're looking beyond the disease and the illness and the injury, whatever, and we're looking more at the person in their own context. And context is very, very, very important. Just like anyone who is in general practice or primary healthcare, the importance of context, social or whatever it is. I do have a lot of slides with a lot of words, but we're not going to read them all. I'm just going to pinpoint some things. Common and accurate assumptions about nursing. Number 1, nursing is a basic fundamental human act. Yes, it is, or parts of it are, but it takes a lot to be able to hold a hand and empathize. Again, whatever empathy means. We'll discuss that. Nursing happens in a hospital, care home, or whatever clinical setting. That's a wrong assumption. I mean, I'm a nurse, I don't work in a hospital. I still consider myself a nurse. My wife is a nurse and she works in a clinic. Not a hospital, she deals with cancer survivors, and it's a purely nurse-led service, nothing to do with biomedicine per se. Nursing is a prescriptive activity, the regulation that you mentioned earlier, within strict regulated instructions. We get this quite a lot in Malta. You suspect, as a triage nurse, you suspect child abuse. You need to inform the doctor because the doctor will have to inform the social worker. And I challenge nurses and I ask, but why? Why is it such a problem for you to be able to discuss this with a social worker? And they tell you because that's the rule. Get me the rule. There's no rule. It's always more convenient to pass that on to someone else. Nursing is a skill-based activity. Actually, during my research, now this is about 10 years old, during my research, one of the consultants said, you know what's the main difference between nursing and paramedicine and medicine? Is that we deal with the investigative and you deal with doing things. I'm just putting them out there for your thoughts, etc. He was a medical consultant, this person. Okay, so Most of you have heard about this definition of nursing. I went by the traditional for a specific reason. And we're not going to go through them all, just some important parts. Something that the person would be able to perform unaided if he had the necessary strength, skills, whatever. So, as nurses, traditionally speaking, we are there to support patients in those activities that now he can't or she can't do because of the injury or the illness. It's always about supporting the patient. It's never about giving a drug in itself. We give a drug, we do an intervention, we do whatever, because the patient can't do it himself or herself, or doesn't have the necessary knowledge, which implies that education is very, very, very important. And when we talk about patient education, we're talking about empowerment. Empowerment to achieve autonomy. And this can happen even in pre-hospital care. It's in pre-hospital care something that usually nurses challenge me. The most common example they give, especially in Malta, is this. You have someone who is 90 years old, has 90 years old, type 2 respiratory failure, he has been smoking since the age of 15. Yes, in Malta. What health education would you give? Well, definitely not about smoking cessation, because anyway it's too late. But there's other education that you can give. What are the signs and symptoms? When to call? What to do when these things happen? So yes, brief opportunistic advice is part of achieving a degree of autonomy. And that's part of pre-hospital care as well. Again, we're not going to go through it. The ENA's definition of emergency nursing, because that's the closest we get here in Malta. I mean, emergency nurses go out on ambulances. And it's the most complex definition there is, it's the most multifaceted definition there is. What the part I like most is the middle part, which says, so emergency nursing, blah, 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 and occurs in a variety of settings. Up till a couple of years ago, and when I say couple, it's 2 or 3 years ago, there was still a conversation that, well, a nurse is meant for hospital. If you go out, you're called a paramedic. I mean, let's not get lost in whatever words you want. Ultimately, there's nursing to be done. Small n nursing. I won't be offended if a paramedic, and let's say paramedic because that's comparable, if a paramedic says that I provide nursing care to a patient, well, that's fine, if that's what the patient needs. The capital N nursing to me means the regulatory body registration. I mean, you can't be a care worker calling yourself a nurse. Small n is what even the mother does to her child, the actual nurturing part of things. And we all do that. The same consultant who said that earlier also told me, I was debating with him about paramedics and nurses and stuff like that, and he said, don't think that empathy and emotional support is only nursing. Even, and I'm quoting the exact words, even paramedics have this thing. And that's the pre-hospital care definition, which is basically care that happens outside of hospital in an emergency. So not to confuse pre-hospital care with primary health care, which incidentally all carry PHC. So after long conversations with experienced nurses, experienced doctors who work in pre-hospital care, we came up with these 5 main functions. So number 1 is to provide emergency and immediate care to patients, to provide support to patients during whatever care is required, sometimes to discharge patients or refer patients, to act in our case as a satellite or gatekeeper to the department, because you are part of the department out there. That's maybe an advantage that we have, and to participate in anything operational that goes on. Again, nothing different from paramedic practice. So, emergency goals, what are they? Look at the first one. To establish a partnership. And don't get me wrong, I understand the importance of all the complex skills and all the advanced skills and that we need to train for them. But ultimately, it's about a relationship with a patient. And that relationship, depending on how able we are to form that relationship, the patient will respond differently to our treatment. And we've seen very good nurses, by which I mean able to do most of the interventions, not satisfying what we would call good nursing care, simply because there was no meaningful relationship with the patient, even at the end of life. Even at the end of life. So the first one is very important. The other three emerge from the nursing theories. So, it's useless going through them. This is a very brief picture of what actual pre-hospital care is. Now, it may be different for most of you because you come from specific settings, especially remote and military medicine. I understand it's a bit different. But within the civilian settings, within the normal ambulance services, it's usually divided like that. 1/3 real acute patients with ABCD compromise. And over there, I'm stretching it from resuscitation to someone with type 2 respiratory failure, signs of, circulatory failure, things like that. The rest are patients who don't actually need any acute intervention. But they are still our patients. And unfortunately, it's not once or twice that I discuss with especially the more experienced nurses. And I would tell them, listen, for example, there was transportation. And I understand that in some countries this would be unheard of. Why was the nurse sitting in front with a patient loaded at the back? Because there was nothing I could do. Let me say it again, maybe it didn't transpire. Why was a nurse sitting in front of the ambulance with a patient loaded at the back? Because there's nothing that as a nurse I could do. Meaning, I couldn't do an intervention. Well, talk to the patient. Maybe you identify something that's not biomedical. Like, for example, poverty. Like, for example, abuse. Like, for example, psychological distress. We talk a lot about biomedical care. Priorities, ABCs, agreed, there's nothing to discuss much over there. We agree they are important, they are priorities. Those of you who work in universities, you know that everything is urgent and everything is a priority, especially deans and rectors. For them, everything is urgent and everything is a priority. I usually very cockily say, well, if everything is urgent, then nothing is. If everything is a priority, then nothing is. So despite we talk about medical priorities, there might be other things that at this moment in time are not priorities, but they are equally important. Like it was explained to us earlier today. We talked about nursing care, or briefly. There's a buzzword we like to use in nursing, holistic care. And we tend to try to define holistic care in practice, but we're never successful in that. We have an academic definition for it, but as was highlighted yesterday, something that does not work is an academic concept. So when I say holistic over here, it's about something that includes biomedical, psychosocial, and functional. And it has to include everything. So when you're, taking care of a patient with hypoglycemia, you're going through your ABCs and your cannula and your glucagon and your dextrose, whatever. But then there's the next step. Why did that hypoglycemia happen? Could it be it's not a biomedical problem? Could it be it's not a problem of adjustment of drugs, etc., but something social? Could it be that patient in sepsis was prescribed antibiotics that he couldn't afford to buy? To help us a bit in practice in nursing, we use nursing models. They are not used as we use the ABCD, but they are implied. So most experienced nurses would have these at the back of their mind and they hit them all. The simplest version would be something like this, what Jones would call the components of life framework. When I teach students emergency nursing, we start off with this, and then they develop that into their everyday practice, and it becomes automatic. So ABCs, communication, mobility, the ability to maintain safety, health and social well-being, personal care, eating, drink, and elimination. That's what makes a patient, that's what makes a person. And you need to address everything, even in hospital care. I think this morning, in one of the presentations, this was crystal clear. Sometimes it's not about the illness only, or the illness itself. Sometimes it's about the other things. I remember one old lady who died in the ambulance, and she was saying, not died, she went to cardiac arrest and eventually died. And she was saying she wouldn't have called the ambulance if she couldn't stand the cold anymore. Now keep in mind, this is Malta. Our idea of cold is different from most of you. For us out there, it's cold today. So those of you who are left having lunch in the yard, that's why we didn't come, because it's cold. But her call wasn't about her physical symptoms, it was too cold. And she lived in a very poor setup. If it wasn't for that setup, she wouldn't have called. I'm just showing this for completeness sake, because I'm aware there are nurses in the group. Obviously enough, there are the most complex versions. The more complex versions, like the traditional Roper et al. And this is what we actually do. What I do with students is this. I divide them in groups and I tell them, listen, think about your day and list the things you do during the day. Now imagine you have a stroke, God forbid. How would that stroke affect these things? And that's in first year. Unfortunately, I do the same exercise with the same group in third year. And in third year, I give them an unconscious patient and I tell them, discuss the nursing care of an unconscious patient. And they are very good at prescribing blood tests, x-rays, scans, drugs, and things like that. No one mentions elimination, hydration, comfort, pressure sore prevention, PEs and DVTs. What affects dependence? The biology, age, illness, whatever it is, disability, whatever it is. The psychological. How many times did we respond to an emergency call, a prehospital call, and we saw that there were symptoms, but ultimately the problem was more of a psychological nature? And you say, well, I'm going to transport this patient not because he has medical needs, but because I need to get him out of here. Sociocultural, same thing. How many times did we transport someone simply to get him out of that social situation, out of that whatever it is? I remember a family, initially they used to call ambulances, eventually they just started coming by themselves. Every single evening they used to come, mother, father and daughter, in the emergency department, just to stay there for the night. And this is Malta. Simply to stay there for the night. Initially they started calling ambulances, something like, because she has a cough and she has asthma, the child. They all get a transportation to hospital, then they disappear in the waiting area. We used to argue a lot with consultants and doctors. Kent is laughing. Adam Yiju. Okay, it appears that the habit is still there. We used to argue a lot with consultants because sometimes they were refused care. Whereas I understand that there might not be the need for medical care, there is a social problem over here. No one would come to the emergency department simply for the, I don't know, the entertainment of it. Maybe a nurse would or a doctor would, but not. Environmental. Something interesting what happened a couple of years ago here in Malta was this. They noticed an increase in ambulance calls for respiratory illnesses in the elderly. Patients would be admitted without any actual cause, but with shortness of breath, whatever that means, only to be discharged 2 or 3 weeks later being fine. Only to be discharged after a few days being fine, to be readmitted 2 to 3 weeks later with the same symptoms. And because these were strange SOBs, maybe we didn't look at what's going on in the social part of things. Guess what it was? By the way, it was January, February in Malta. Gas heaters. Many patients admitted simply because they were inhaling gas. But because that information was not forthcoming to the emergency department or to the hospital, it required a consultant to do research to be able to pinpoint what the problem was. And politico-economic. In a country like Malta, small size, the politico-economic factors influence us quite a lot. Okay, to start wrapping up a bit, the most important parts. We usually as adults have a sense of control of our situations. Then something happens, an emergency happens, and it's unexpected. So there's loss of control, there's loss of autonomy. And there's a change in self-image or perceived autonomy. So what happens is that we don't contribute anymore to the interaction. Now, for good care to happen, whether it's nursing or something else, you need interaction and communication with the patient. The relationship is very, very important. And that relationship happens through trust. And I skipped 2 slides on purpose because I understand we're pressing, to talk about these 4 things. Very quickly. Number 1, respect. We need to respect the patients as fellow human beings. They are not there at our service, we are there at their service. Number 2, empathy. Empathy is a sore point for me personally. We don't know what empathy is. We think that by saying, hey, I know what, I can understand what you're going through, we're being empathic, or we're not. There was a good definition that I challenged quite a lot. Empathy is when you put yourself in the patient's own shoes. Who cares how you feel in the patient's shoes? What we care about is how the patient is feeling in his or her own shoes. I've passed through an experience with empathy, and we don't even understand how this pseudo-empathy affects trust. My second daughter was born still unexpectedly. And by empathizing, people started saying, now you have an angel in heaven, who cares? I want my angel over here. You're not the only couple to have been passing through this. People get on with it. The other one was, you know how many we see of these every month? That's fine. The consultant actually started stating the statistics, all in good faith to empathize, but we just lost trust. And both myself and my wife, we are both nurses. Yes, boring life. So, confidence, the confidence we project. If you're there with a needle and you're going to poke someone with a needle and you don't show confidence, there's no trust. And the interaction is very important. Understanding how interactions happen and how we interact with patients is fundamental for good nursing care to happen, small N nursing care. Trust doesn't happen in a vacuum. We need to create the space and the conditions for trust to happen. That's not on the patient, that's on us. For trust to happen, we shouldn't expect the patient to trust us. We need to create a space and the conditions for trust to happen. We need to allow the patient to express the feelings, we need to acknowledge the fear, we need to encourage the patient to express their thought and the concerns. We need to encourage the patient to verbalize the needs so that we understand better. And we should expect the patient to contribute to care. Because evidence shows that patients who contribute to care, they fare much, much, much better. When this does not happen, care fails. The medical care may still happen, so the patient might still receive the treatment that he needed, but the meaningful relationship is not created. And creating a meaningful relation is very, very, very important. One last slide and then we conclude. What may lead to failure in holistic care? Number 1, an emphasis on pre-hospital assessment and care that remains biomedical. Go to any course you want and see the pre-hospital course you want and see the nursing component, small and nursing care, holistic care, etc. that is within those courses. I've only read one paper coming from a paramedic that deals with nursing. Was it sheep vomit? Try to look literature and see the nursing, in inverted commas, component in pre-hospital courses, not even if it's meant for nurses. If we lack to acknowledge the non-medical aspects of care, holistic care will fail. Number 2, the rigid biomedical assessment. Now I am all for acronyms and mnemonics and ABCDs, etc. Kenneth is looking at me like this. However, when we adopt a rigid structure that doesn't allow much movement, we tend to miss on things. Yesterday when there was a conversation going about the ABCs, quoting academic liberty, we do not strictly teach a linear ABCD-EF. We teach a cyclical ABCD-EF. Or we discuss it more than anything. Simply because it allows a bit more movement and freedom. So when we are rigid and we are strict, there's very little space for the other parts to happen. And it gives us a false reassurance of complete care, because it's stick down on a document. And that is where the movement between doing for the patient and being with the patient becomes important. It's about doing for the patient and being with the patient. So, the 4 main points out of this brief presentation is this. Number 1, pre-hospital and emergency professionals do not exist in silos. We are here, we share common knowledge. Some of us have more advanced skills, some of us have different skills. it's important that ultimately our aim is to collaborate and cooperate towards the same goal. Number 2, nursing is not merely a set of skills. There is a process that enables the patient to retain or regain autonomy, which starts in pre-hospital care. And this is all towards independence as much as possible. Number 3, pre-hospital care goes beyond the ABCs. Those are medical priorities, but they are just priorities. There's other important things that need to be addressed. Sometimes the priorities are actually non-medical. And one last point, pre-hospital care does not happen in a vacuum. So we need to create the space and the context for the care to happen. And that's on to us, not on the patient. One, like my concluding slide is this. I don't know if there's anyone who has read this book. Very easy reading book, my style of book. Chapters are 3 to 4 pages long. Each chapter is a different story from a different ER nurse. Has nothing to do with nurses. It is different nurses who have been working in various settings, emergency department, military, evacuation, pre-hospital, anything you mention it. And it really shows the true shape of nursing care beyond the regulatory bodies. For those of you who are nurses and have worked in emergency departments, or those of you who have been through a lot, this type of book can shake a bit that tiny little box we have in our brains that we try to protect from opening. Thank you.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.